بسم الله الرحمن الرحيم. Congenital heart diseases. The most common is congenital ventricular septal defect. Classification of congenital heart diseases. Acyanotic congenital heart lesions causing left to right shunt, like atrial septal defect, ventricular septal defect, persistent ductus arteriosus. Acyanotic congenital heart lesions causing obstruction to the flow within the heart or vessel, pulmonary stenosis, aortic stenosis, coarctation of the aorta. Cyanotic congenital heart lesions, tetralogy of Fallot transposition of great vessels. Investigation, echocardiography. An accurate diagnosis is required. Hemodynamic data and response to drugs are required. Peripheral structures in the lungs, branches of the pulmonary arteries, need to be visualized. Therapeutic procedures, septostomy, balloon dilatation need to be performed. Atrial septal defect. Types of atrial septal defect. We have three types. Secundum atrial septal defect occurs in the middle of the atrial septum and accounts for about 70% of all the atrial septal defects. Sinus venosus ASD, where the superior vena cava and right atrium join. Primum ASD often occurs along with an abnormality in the mitral valve and or tricuspid valve and causes some regurgitation. A patent foramen ovale PFO. Such picture shows ASD. Surgical procedures. Ostium secundum, direct closure, patch closure using pericardial or dacron patch. Ostium primum ASD, patch closure, pericardial or dacron patch. In the presence of mitral regurgitation, due to cleft anterior mitral leaflet, the cleft mitral leaflet is approximated to reduce the regurgitation. Sinus venosus defect, patch closure. Patent foramen ovale, direct closure. Ventricular septal defects. Types. Perimembranous, in and around the area of membranous septum. Inlet, beneath the septal leaflet of the tricuspid valve. Outlet, beneath the pulmonary valve. Muscular, in the muscular ventricular septum. Such picture to show the types of VSD. Surgical procedures. All defects are closed with dacron patch. Symptomatic multiple defects in infancy. A preliminary pulmonary artery banding to protect against pulmonary hypertension and relieve heart failure is followed later by total correction, debanding the pulmonary artery, and patch closure of septal defects. But nowadays, we can do VSD closure for a baby for 1 kilogram or 1.5 prematures, whatever. Patent ductus arteriosus. Patent ductus arteriosus is a remnant of a shunt between the aorta and pulmonary artery during intrauterine aorta, which is supposed to be ligamentum arteriosum after delivery. But if it is still patent, is make shunt, that's why called patent ductus arteriosus. Treatment of patent ductus arteriosus is closure. But if the baby is premature, we have to try medical treatment like endomethacin, sometimes give good results. Surgically, by double ligation and division, or video-assisted thoracoscopic surgery, or by cardiac catheterization, and a coil or occluder is introduced into the open PDA, preventing the blood from flowing through it. Pulmonary stenosis. We have types of pulmonary stenosis, and according to the type, we are gonna do a surgical procedure. If pulmonary stenosis is valvular, so surgical procedures is going to be condylotomy using cardiopulmonary bypass, subvalvular infundibular hypertrophy, resection of hypertrophied myocardium through pulmonary arteriotomy, supravalvular, a patch of pericardium is placed to enlarge the pulmonary artery. Aortic stenosis. Coarctation of the aorta. Aortic coarctation is narrowing of a part of the aorta. The coarctation is located on the descending aorta near the heart, usually immediately past the point where the subclavian artery exists, the aorta in its way to the upper body. Such picture showing coarctation of the aorta and narrowing of part of the aorta. Surgical treatment. Balloon dilatation, diaphragmatic type. Resection and end-to-end anastomosis, excellent in infants and children. Patch aortoplasty with vortex or Dacron. Resection and tube graft replacement. If the aorta not mobilized and I can't approximate the both ends, I have to use graft. Subclavian flap aortoplasty. Recurrent coarctation is usually treated by non-surgical balloon dilatation or by implanting stent using cardiac catheterization. Such picture for coarctation showing procedures for synthetic patch, tube graft, and subclavian flap. Tetralogy of Fallot. Tetralogy of Fallot has four key features: a ventricular septal defect, pulmonary stenosis, overriding of the aorta while lies directly over the ventricular septal defect, and right ventricular hypertrophy. Surgical procedures. Palliative procedures if pulmonary arteries are small. Systemic to pulmonary shunt. Plalactocyc subclavian artery is divided distally and anastomosed to the pulmonary artery. Now we use prosthetic conduit, Gore-Tex tube graft between the two vessels, modified plalactocyc shunt. Such picture to show the shunt. Here. Total correction is the main target for Fallot tetralogy. If pulmonary artery and branches are good for size, a patch is placed in the right ventricular outflow tract, pulmonary annulus, and pulmonary artery to relieve the right ventricular outflow tract obstruction. The hypertrophied infundibular muscle is resected. The ventricular septal defect is closed with Dacron patch. Transposition of the great vessels. Transposition, that means that the aorta rising from the right ventricle and the pulmonary from the left ventricle. Surgical collection, creation of intra-atrial baffle, Senning procedure using normal atrial septum, master procedure using pericardium, anatomic collection at arterial level, switching the pulmonary artery and the aorta, and re-implanting the coronary arteries. Cardiac tumors. Types: primary and metastatic. Cardiac tumors. Primary, like benign cardiac tumors, like benign cardiac tumors, 75%, myxoma, rhabdomyoma, fibroma, lipoma, teratoma. Malignant, 25%, sarcoma and teratoma. Metastatic, carcinoma from lung and breast, sarcoma and melanoma. Myxoma, the commonest cardiac tumor, 75% over the cardiac tumors. Smooth, firm, spherical, encapsulated mass. Loose gelatinous material. Pedunculated airy percent attached to the septum in the left atrium. Such a picture to show myxoma. Clinically, systemic manifestations, embolic manifestations, mechanical obstruction like ball valve thrombus. Diagnosed by echocardiography, treated by surgical excision of the tumor with attached intra-atrial septum and patch closure of the atrial septal defect to avoid recurrence. Pericardium. Constrictive pericarditis. The commonest cause of pericarditis are idiopathic tuberculosis. Here, double-layered thin pericardium membrane are turned into a single, thick, rigid, fibrous capsule, which restricts diastolic feelings of the heart and leads to right-sided congestive failure. This usually due to the healing of tuberculosis or purulent bacterial pericarditis. Treatment is by pericardiectomy, through sternotomy or thoracotomy, whatever, with or without extracorporeal circulation. Pericardial effusion. It may be malignant, 75% due to metastasis from breast or lung cancers or direct invasion from mediastinal tumors, and may be benign, 25% due to infection, trauma, uremia, whatever the cause. Pulses, paradoxus, and Bake's triad, distended neck veins, muffled heart sounds, hypotension, are clinical findings in acute cardiac tamponade. Echo is diagnostic. Treatment: if there is no hemodynamic compromise, treat the underlying cause and echocardiography-guided pericardiocentesis. Impending or acute tamponade, volume expansion to increase diastolic filling, pericardiocentesis under local anesthesia using parasternal or subxiphoid route, guided by echocardiography. Drainage catheter may be positioned. Surgical decompression, indication clotted blood or trauma or purulent pericarditis or liquelated effusion or pericardial biopsy. Resection of a portion of the pericardium, creation of pericardial window to drain pericardial fluid. Approaches: subxiphoid, left anterior thoracotomy, video-assisted thoracoscopic surgery, or VATS. Aorta. Aortic dissection. Definition: tear in the intima of the aortic wall allows the blood to enter and flow in a false channel. The true aortic lumen and false plane of dissection. Channels are separated by dissecting membrane or flap that contains aortic media and intima. Diagnosis is based on high index of suspicion, pain, pallor, pulseness, paresthesia, and paralysis. CT, MRI, transesophageal echo, chest X-ray. Chest X-ray shows wide mediastinum. Fate: weakening of the outer wall of the aorta resulting in rupture or formation of aneurysm. And if it ruptures, the patient is gonna die. Progress and occlude aortic branch vessels causing myocardial infarction, stroke, kidney failure, bowel ischemia, paraplegia, limb ischemia. Disrupt aortic valve annulus, resulting in valvular insufficiency and cardiac failure. Re-entry. Classification: Type A, proximal dissection involving the ascending aorta. Type B, distal dissection beyond the left subclavian, involving ascending thoracic aorta. Staging: acute, subacute, chronic. Treatment: immediate surgery, tube graft replacement of the ascending aorta through the sternotomy. Involvement of the aortic valve annulus requires resuspension of the aortic cusps or aortic valve replacement. The coronary ostia may need to be implanted into the graft, Bentall's procedure, or David's procedure, whatever. If we preserve the native valve, is gonna go because it's David procedure. If we replace the valve, it's gonna be Bentall's operation. Type B, stabilized medically, may not require immediate surgery. sedation, analgesia, lower blood pressure to as low as 900 mm Hg, slow the pulse to make the heart beat within less force. If not stabilized medically, surgery with excision and tube graft replacement of the upper thoracic aorta through left thoracotomy. Thoracic endovascular aneurysm repair (TEVAR) instead of surgery. Aortic aneurysm. Definition. It's an area of bulging in the wall of the aorta, weakening by atherosclerosis, degenerative disease as Marfan syndrome, syphilis, or trauma. Sacral or diffuse aneurysm in the ascending aorta or descending aorta. How are thoracic aneurysm diagnosed? X-ray, CT, MRI, echocardiography. Treatment: ascending aorta and aortic arch aneurysm, replaced with edacron tube graft when the diameter is over 5 to 6 cm, depending on the location and rate of recent growth and onset of chest pain. If the aortic valve is damaged, it also will need to be replaced or repaired. Then the procedure is done. Descending thoracic aneurysm, replaced with tube graft through the left thoracotomy. However, techniques of endovascular abdominal aortic aneurysm repair are now applicable to some descending thoracic aneurysm. In this procedure, two small incisions are made in both groins and a graft is placed inside the aneurysm in order to exclude it from the circulation. Endovascular stenting, Seldinger technique. Thank you.